The biological marvel of creating a new human being is, well, it's just an incredible journey, isn't it? It demands a tremendous amount of energy and critically very specific building blocks. As future nursing professionals, truly understanding how to support this intricate process through optimal nutrition isn't just important, it's absolutely critical. Today, we're embarking on a deep dive into nutrition for childbearing. We've distilled a stack of research, detailed guidelines, and comprehensive clinical information that lays out exactly what's needed for optimal health during pregnancy, the postpartum period, and lactation. Our mission for you, the listener, is to extract the most impactful nuggets of knowledge and practical, actionable insights. We'll delve into the why behind dietary recommendations, the what to look for in terms of signs and symptoms of deficiency, the crucial pathophysiology, and the how for effective nursing care and interventions. Think of this as your shortcut to being well-informed on a topic that directly impacts the health trajectory of two patients, mother and baby. So let's unpack this right from the start. Why is nutrition during pregnancy, postpartum, and lactation so much more than the old adage of eating for two? What's the profound overarching importance here that we as nurses need to grasp?
Well, what's truly fascinating here is the intricate link between nutrition and both maternal and fetal health outcomes. It's a connection that spans from conception right through the baby's first year and genuinely influences their long-term health trajectory. It's not just about providing enough calories, it's about supplying the precise nutrients required for rapid fetal growth and development. And if those are inadequate, it can trigger significant complications for both mother and baby. For example, good nutrition helps prevent issues like gestational diabetes, preeclampsia, or serious neural tube defects. Crucially, it directly supports the mother's own profound physiological changes, increased blood volume, tissue growth, and it absolutely dictates the quality and quantity of breast milk produced during lactation. So for your nursing practice, this foundational understanding means your role isn't just about, general advice. It's about comprehensive nutritional assessment, tailored patient education, and ongoing support to literally build health from the ground up.
That makes perfect sense. Building on that, let's talk about weight gain during pregnancy. It's a topic that often carries a lot of misconceptions for patients. What are the actual recommendations? And maybe more importantly for us, what happens physiologically when a woman gains too little or too much? What are the nursing implications we need to be aware of?
Yeah, you've hit on a core area for patient education. Our sources clearly show that appropriate weight gain is a critical determinant of fetal growth. We have very specific recommended ranges based on the woman's pre-pregnancy body mass index, or BMI metric you'll be pretty familiar with from your studies. For a woman with a normal BMI, say between 18.5 and 24.9, the target is 25 to 35 pounds, or about 11.5 to 16 kilograms. If she's considered overweight, BMI from 25 to 29.9, the target drops a bit to 15 to 25 pounds. And for individuals with obesity, so a BMI of 30 or higher, the recommendation is even tighter, 11 to 20 pounds. Now, when we look at insufficient weight gain, and the marker here is often less than 1,500 grams or about 3.3 pounds in the second trimester, it directly compromises the maternal nutrient supply to the fetus. This can potentially lead to placental dysfunction and impaired fetal growth.
Okay, so what does that look like clinically?
Well, it can result in low birth weight, or LBW, infants, or small for gestational age, SGA, infants. And it significantly increases the risk of preterm birth and even, sadly, infant mortality. It can also hinder the initiation of breastfeeding. So, as nurses, identifying this early through regular weight monitoring and detailed dietary assessment is absolutely crucial.
Right. And what about the flip side? Gaining too much weight seems to be a widespread concern for many patients. What are the specific risks there?
Absolutely. Excessive weight gain, particularly more than 20 kilograms or about 44 pounds, is a major concern with its own significant set of risks, really stemming from altered metabolic processes. For the mother, it substantially increases the likelihood of developing gestational hypertension, preeclampsia, and gestational diabetes, basically as the body struggles to manage those increased demands. It can also lead to prolonged labor or increase the need for a cesarean birth.
And for the baby?
For the baby, excessive maternal weight gain is linked to macrosomia. That means a large baby, often weighing over 4,000 grams, which raises the risk of birth injury. It's also associated with stillbirth and certain congenital anomalies, including neural tube defects, and it significantly increases the child's risk of obesity later in life. And for the mother, it often leads to significant postpartum weight retention and a higher risk of obesity in future pregnancies. It sort of sets up a cycle.
Wow, yeah.
So this presents a real challenge for us as nurses. How do we effectively guide patients through this Goldilocks zone of weight gain? It really starts with assessing their pre-pregnancy BMI. Then, regular weight monitoring throughout pregnancy is essential, coupled with individualized nutritional counseling. Your role is to help the patient understand that the pattern of weight gain is just as crucial as the total amount.
The pattern, can you elaborate on that?
Sure, an ideal gain is about 0.44 to 0.58 kilograms, or roughly 1 to 1.3 pounds per week during the second and third trimesters for women starting at a normal weight. This precise monitoring and targeted education are vital nursing interventions. It's not about judgment, obviously, it's about informed supportive care.
That's a really clear roadmap for weight gain. Okay, having laid that crucial groundwork, let's now drill down into the building blocks themselves, the macronutrients. How do these daily dietary needs truly shift when a woman is, well, nourishing too?
Yeah, good question. And if we tie this back to the overarching goal of supporting growth and those profound physiological changes, it's all about meeting those significantly increased demands. Let's start with energy. A non-pregnant adult female typically needs around, say, 200 and 477 kilocalories per day. During pregnancy, this caloric intake needs to increase by about 340 kilocalories per day in the second trimester and then jump again to 452 kilocalories per day extra in the third trimester. For lactation, the demands are equally high, an additional 330 kilocalories per day for the first 6 months and 400 kilocalories per day for the second 6 months.
And it's not just any calories, right?
Exactly. What's paramount for nurses to emphasize is that this additional energy must come from nutrient-dense foods, not empty calories. Chips and soda aren't going to cut it. You'll be guiding patients toward foods that offer the most nutritional bang for their buck. Next, protein. Protein needs jump significantly from about 46 grams per day for non-pregnant women to a consistent 71 grams per day throughout both pregnancy and lactation. This surge is absolutely vital for the rapid tissue growth of both mother and fetus and for robust milk production later on.
Good sources being.
Excellent sources include lean meats, fish, poultry, eggs, legumes, beans, lentils. As nurses, you'll assess protein intake and counsel on diverse protein sources, especially important for patients with dietary restrictions like vegetarians. Then there's carbohydrates. They're the primary energy source. Recommended intake increases from 130 grams per day non-pregnant to 175 grams per day during pregnancy, and then up to 210 grams per day during lactation. Whole grains are highly preferred here. Think brown rice, whole wheat bread, oats, as they provide essential energy, along with beneficial fiber and additional micronutrients.
And that fiber helps with constipation too, which is common.
Exactly, a very practical benefit. Finally, fats. Fats are crucial, not just for energy, but also for the absorption of fat-soluble vitamins A, D, E, and K. Our sources specifically highlight docosahexaenoic acid, DHA, and arachidonic acid, ARA. Both are omega-3 fatty acids as particularly important for optimal fetal visual and cognitive development. Brain food, essentially.
Where do patients get those?
These can be found in fatty fish like salmon, though we need to be careful about mercury, we'll get to that, and also some fortified foods like certain eggs or milks. The patient education should underscore the importance of healthy fats, explaining where to find them. And it's also important, as you interact with patients, to identify and respect dietary patterns, like the hot and cold foods concept in some cultures. This helps you tailor nutritional advice in a culturally sensitive and effective way.
Okay, this is where it gets really interesting and maybe a bit overwhelming with the sheer number of specific vitamins and minerals. Why are these seemingly tiny components so vital, and what are the specific clinical consequences, the pathophysiology, if a woman doesn't get enough, or in some cases, too much, and what are we as nurses looking for and doing?
That really is the million-dollar question, isn't it? Because a deficiency in even one micronutrient can have these cascading effects on such a complex process. Each plays a specific, vital role, and their absence can lead to significant pathophysiological consequences that you, as nurses, will definitely encounter. Let's start with vitamin A. It's crucial for fetal growth and cell differentiation. But here's the critical balance. Excessive intake, especially from certain medications like isotretinoin or acistradin.
Things like Accutane.
Exactly. Those are highly teratogenic, meaning they can cause severe, lasting developmental abnormalities in the fetus, major birth defects. Conversely, a deficiency in vitamin A can lead to spontaneous abortion and maternal night blindness. So, as nurses, taking a meticulous medication history and educating on proper intake, usually through diet and prenatal vitamins, not megadoses, is paramount. Vitamin D is essential for calcium absorption and bone mineralization. A deficiency can cause hypocalcemia and hypophosphatemia, which translates to poor fetal bone and dental formation.
So advising on fortified milk, maybe some, say, sun exposure.
Right. Exactly. Sources like fortified milk and controlled sunlight exposure are key recommendations we'll make. Vitamin E acts as a crucial antioxidant, protecting cells from damage. A deficiency can manifest as anemia in the mother and, critically, hemolysis. That's the premature destruction of red blood cells in the newborn. Recognizing these, sometimes subtle signs, is vital for early nursing intervention, ensuring cell integrity for both mother and the developing baby. Vitamin K is a unique case. Newborns are naturally deficient, which puts them at risk of hemorrhagic disease of the newborn, serious bleeding. This is precisely why a prophylactic dose of vitamin K is administered at birth, a critical nursing intervention you will perform routinely.
Okay, that makes sense. What about the B vitamins? There are quite a few.
Yes, the B vitamins are powerhouses. Vitamin B6, or pyridoxine, is key for the metabolism of amino acids during pregnancy. It's also sometimes used off-label to help manage nausea and vomiting of pregnancy, morning sickness.
Ah, right. So for that morning sickness, nursing care involves...
Often advising frequent, small, bland meals, maybe dry crackers before getting out of bed, avoiding strong odors. Those are usually the first line of defense. The other B-complex vitamins like thiamine, riboflavin, and niacin serve as coenzymes. Basically, they help unlock energy from food and ensure proper nerve and muscle function. Their increased demand in childbearing isn't just about general vitality, it's about fueling the immense metabolic work of pregnancy and lactation and ensuring robust neurological development for the fetus. So, as nurses, we must champion a diverse diet to cover all these B vitamin bases to support this foundational energy production. And vitamin B12 is essential for red blood cell formation and neurological function.
And this is a big one for vegetarians or vegans.
Exactly. Vegans are at particular risk of deficiency because its primary sources are animal products. A deficiency can lead to severe forms of anemia in the mother, pernicious anemia, megaloblastic anemia profoundly impacting her energy and oxygen delivery, and posing neurological risks for both mother and baby. So you'll be assessing dietary patterns closely and advising on necessary supplementation or fortified foods. Folic acid. This one is absolutely critical, non-negotiable really. The daily intake recommendation during pregnancy is 600 micrograms, which is up from 400 micrograms for non-pregnant women, and it's 500 micrograms during lactation. This higher intake is vital to prevent devastating neural tube defects like spina bifida and anencephaly.
And the recommendation is even before pregnancy, right?
Yes. The CDC actually recommends that all women of childbearing age consume 400 micrograms daily because these defects occur so early in pregnancy, often before a woman even knows she's pregnant. Nurses should emphasize sources like dark green leafy vegetables, legumes, oranges, and fortified cereals, stressing that early and consistent intake is paramount. Vitamin C is important for fetal tissue formation, collagen synthesis, immune function, and a key point, it significantly enhances iron absorption.
Which is a perfect lead-in to iron.
Indeed. Iron, which is perhaps the most common deficiency we encounter in pregnancy, needs increased significantly from 18 milligrams per day non-pregnant to 27 milligrams per day during pregnancy. That's a huge jump. It's needed to support the increased maternal blood volume and fetal liver iron storage. A deficiency leads to iron deficiency anemia. You'll see the classic signs and symptoms: pallor, profound fatigue, shortness of breath, increased susceptibility to infection, and of course, low hemoglobin and hematocrit levels on labs.
And the impact on the baby.
For the baby, maternal iron deficiency is associated with low birth weight, preterm birth, and increased infant mortality. Really serious outcomes. For you, the nurse, this means rigorously monitoring lab values like hemoglobin, hematocrit, and serum ferritin, which is a good indicator of iron stores. Your patient education will be crucial here. Advising on improving absorption, like taking iron supplements with vitamin C or on an empty stomach, and avoiding inhibitors like calcium supplements, coffee, tea, high-fiber food, phytates, and spinach oxalates around the same time as the iron source.
And what about pica? Is that related?
Yes, good point. Pica, the craving for non-food items like clay, dirt, laundry starch, or large amounts of ice, can actually be a symptom of iron or sometimes zinc deficiency. If a patient reports this, it definitely signals a need for further assessment of their nutritional status. Moving on, calcium. Essential for the mineralization of fetal bones and teeth, and also for maintaining the mother's own bone density. Intake recommendations are 1,300 milligrams per day for adolescents aged 14-18 and 1,000 milligrams per day for women 19-50. These needs don't actually increase during pregnancy, but meeting the baseline is critical. Supplementation may be needed if dietary intake is low, especially for lactose-intolerant women. You'll be assessing dietary patterns, dairy intake, fortified foods to guide these recommendations. And finally, briefly, phosphorus, zinc, magnesium, and iodine each play specific, vital roles in development, metabolism, and thyroid function. Iodine, for instance, is crucial for preventing congenital hypothyroidism and associated neurological conditions in the fetus. Ensuring adequate intake, often through iodized salt and diet, is important.
Okay, that's an incredible breakdown of the micronutrients and our role in ensuring patients get what they need. Thanks for clarifying the pathophysiology and nursing actions there. Beyond these general guidelines, what about some of the more complex patient situations or unique challenges that nursing students might encounter? What special nutritional considerations come into play for those specific populations?
That's a great question because in practice, many factors can profoundly influence a woman's nutritional status during childbearing, beyond just general dietary habits. Let's consider eating disorders, for example. Anorexia nervosa, bulimia, binge eating disorder. The pathophysiology here is rooted in severe nutrient deficiencies and often metabolic disturbances, which directly impact both the mother and the fetus. This significantly increases risks for low birth weight, preterm birth, congenital anomalies, and even cardiac issues in the infant, not to mention the severe health risks for the mother herself. Nursing care in these situations is complex. It absolutely requires a comprehensive, multidisciplinary approach, often involving mental health professionals, dietitians, and physicians. And always maintaining a non-judgmental, empathetic stance toward the patient is critical.
That's vital. What about substance use?
Substance use is another critical area for nursing intervention and education. For alcohol, the message has to be clear. Complete abstinence is the only safe approach. Alcohol can lead to fetal alcohol spectrum disorders, causing irreversible developmental damage. No amount is known to be safe. Nurses must educate on this unequivocally. For caffeine, moderate intake, generally considered up to 200 milligrams per day, which is about 2 to 3 standard cups of coffee, is usually considered safe. But excessive intake is strongly discouraged due to potential links with miscarriage or low birth weight, though the evidence is a bit mixed. As for other drugs like marijuana or illicit substances, they can impair nutrient absorption, cross the placenta, and directly harm fetal development. Nurses must provide impartial, evidence-based education about these risks and strongly encourage cessation, connecting patients with resources. And smoking. Smoking during pregnancy is also strongly associated with lower maternal weight gain, reduced vitamin and mineral status, like vitamin C, and a significantly increased risk of complications like placental abruption, preterm birth, low birth weight, and SIDS. Your role includes supporting cessation efforts and providing resources.
Okay, what about younger mothers?
Adolescent pregnancy presents unique nutritional challenges. These young mothers are still growing themselves biologically, so their nutritional needs for energy, calcium, iron, etc. are even higher than adult women. This requires really meticulous monitoring and tailored education to ensure adequate intake for both the adolescent mother and her developing fetus. You're effectively nourishing growth on two fronts.
And diets like vegetarianism.
Right, vegetarian and vegan diets. While perfectly healthy when well planned, these diets require careful attention to ensure adequate intake of nutrients commonly found primarily in animal products. We're talking specifically about vitamin B12, vitamin D, iron, calcium, and zinc. Supplementation is often necessary for these individuals, especially B12 for vegans. Nurses need to be knowledgeable about appropriate plant-based sources like lentils for iron, fortified plant milks for calcium and D, and know when to recommend specific supplements based on dietary assessment. Finally, we absolutely must always consider cultural influences. Dietary practices vary widely by culture. For instance, some cultures classify foods as hot or cold, which influences choices during pregnancy and postpartum. Nurses must respect these cultural practices, understand their significance to the patient, while still providing the necessary education to meet optimal nutritional needs. It's about finding ways to integrate health recommendations within the patient's cultural framework, not dismissing it. It's about meeting patients where they are.
Wow. Today, we've truly peeled back the layers on nutrition during childbearing, from the profound importance of macro and micronutrients, understanding the critical pathophysiology to deficiencies, to navigating the specific challenges faced by diverse populations. We've highlighted how deeply nutrition impacts everything from fetal development to preventing serious maternal complications, really emphasizing that constant interplay between what the mother consumes and the health outcomes for both. So what does this all mean for you as a future nurse caring for childbearing women? How will this comprehensive understanding of nutritional needs, the disease pathophysiology behind deficiencies, the signs and symptoms to look for, and the specific nursing interventions influence your patient assessments, your care planning, and most importantly, the way you educate and empower new and expecting mothers? Consider how you will apply this knowledge day to day to ensure every mother and baby you care for receives the best possible nutritional support, leading to healthier outcomes and truly a better start to life for families.